because of our latest craze for anti-segment surgery and phaco surgery, and afterwards gradually losing interest in this field of DCR surgeries. So let me tell you an interesting fact that lacrimal diseases are second commonest disease in eye other than cataract and refractive errors. But so many diseases are occurring in the lacrimal sac area was because of lack of proper training and lack of interest, and they are scared of the complications and all those various reasons. Ophthalmologists are not taking active interest in doing these surgeries, and gradually the field is going into hands of ENT people. But it's a very interesting field. Let me tell you my experiences in this field. From 1989 onwards, when I joined my post-graduation at Occuloplastic, staff knows about that thing. We are actually given chances to the DCR surgeries during our junior residency only. From that day onwards, we have been doing the surgeries. After that, I went to Madurai for super specialty. There also lot of one special theatre for DCRs. Morning to evening, the DCRs going on because there are some 2000 OPD every day there. In that, whatever surgeries coming for the sac related problems, special theatre they should give us, and morning to evening we should do the surgeries. So like that, most of them those days, dactyocystectomy, removal of the sac was the very common surgery rather than DCR, because again they were scared of doing DCRs, connecting the both the nasal ligament duct to the nose because of bleeding and complications and all. They were avoiding the surgery. Few people are doing DCRs, and rest of the case are DCT they were doing. But gradually the scene changed now. Everybody is doing DCRs. All the postgraduates are trained DCR, fellows are trained in DCRs. So external DCR became almost second common surgery in ophthalmic practice, other than cataracts. So this is the scenario, and let me tell you briefly about this anatomy of this lacrimal apparatus. Very interesting area. It's not very difficult area also to master, because not much of important structures there. Even we want to damage also, we cannot damage that whatever structures there. It's very simple area. Nasal mucosa to the lacrimal sac. Here you can see. I will show you both detailed picture. So actually this is divided into secretory system and excretory system, two subdivisions. In the secretory system, it includes lacrimal gland and orbital part. You can see here. So here the bigger orbital part and smaller orbital part divided by this levator epineuritis. Lateral expansion of levator separates the two parts. So accessory lacrimal glands are very small, compound, branch, tubular structures located in the light is going off. Okay. Here you can see these are glands of Golgi, glands of Henle, glands of Mann, and these again the lower lid also like this. So various accessory lacrimal glands are there. So coming to the osteologic part, the lacrimal sac fossa is a depression in the inferior medial orbital ring, and maxillary lacrimal bones are there and bordered by anterior lacrimal crest, maxillary bone. These are very important landmarks when we do the DCR surgery. And portion lacrimal crest, lacrimal bone. And fossa is approximately 16 millimeters high and 4 to 9 millimeters wide and 2 millimeters deep. The medial orbital wall, frontal course of maxilla, lacrimal and ethmoid and the lesser wing of synapse. These are the four bones on the medial orbital wall. Frontoethmoidal suture is important in lacrimal surgery because we cannot cross that thing. It will result in CSF rhinorrhea. If you go higher up and triple lining will damage. It marks the roof of the ethmoid, and bony dissection superior to this suture may expose the jewel of the cranial cavity. So you should know very thoroughly about this bony structure there before you attempt this DCR surgery. Here you can see more clearly about the fossa. This is the lacrimal sac fossa, and this is the suture, and this is anterior starts with the puncta. There are two puncta, superior and inferior puncta. Small round oval orifice, orifice in the papilla lacrimalis, and at the rear end of the lid margin, the junction of its ciliated, non-ciliated parts. Sometimes it's difficult to identify when the puncta is sterosed, and stenosis is there. There is a lot of problem in identifying the puncta. So we need to know the gland box. Upper puncta medial to lower. From the medial, upper puncta opens inferior posteriorly and lower superior posteriorly. So here you can see the more clearly about this puncta. This is upper one. This is the lower one. Entering into the lower canaliculus and upper canaliculus, and they usually join into forming a common canaliculus and enter the sac. Sometimes both directly enter the lacrimal sac. So this lacrimal sac continues as nasolacrimal duct. Here it continues into nose. Here below the inferior turbinate into inferior meatus, it opens. So lacrimal canaliculi, first vertical and then horizontal. This particular point you should know, because when we are passing a probe when probing, the direction of the lacrimal canaliculi should be known very clearly. Otherwise, it will result in false passages. So vertical part is 2 millimeters, turns medially at right angle to become horizontal part 8 millimeters. At angle, dilatation or ampulla may be there, sometimes may not be there. Lot of anatomical variations will be there, but in general, this is the structure. Canaliculi pierce the fascia and separately and uniting to enter the lacrimal sac. Stratified form subtilium usually like these tissues. So you can see more clearly here how this superior and inferior, the measurements. See, this is 2 millimeters vertical part, 8 millimeters horizontal part. They will join and enter the lacrimal sac, or directly they may enter the thing. So this 10 millimeters lacrimal sac usually, 12 millimeters LNDO. These are the important dimensions. Again, I tell you, a lot of anatomical variations may be there, but in general, this is the one. Lacrimal fossa, formed by lacrimal bone and protophossal maxilla, the sac closed above and open below and continues with the LND. The sac is enclosed with by periorbita, splits and forms a lacrimal fascia. This nasolacrimal duct, the main area where the problem occurs. NNT is the main area where the obstruction occurs. So, like you should know the details about this nasolacrimal duct, which continues from the lacrimal sac to the inferior meatus. Usually 15 millimeters in length. It lies in a canal formed by the maxilla, lacrimal bone, lacrimal process of the inferior concha. It descends posterolaterally, a surface indication, a line from the medial canthus to the upper molar tooth. This is the surface line you can draw. So this is how this nasolacrimal duct is ending here below the inferior turbinate into the inferior meatus. The nasolacrimal canal organizes the base of the lacrimal fossa and form the maxillary bone laterally and lacrimal and inferior terminates both inferior. Width of the superior opening is only 4 to 6 millimeters. The duct courses posteriorly and laterally in the bone for 12 millimeters to drain into the inferior meatus into the nasolacrimal. There are various walls are there for the proper drainage. There are folds of mucous membrane with no valvular function. The most constant is the valve of Hassler at the lower end. This is the most constant one. Rest of the things may vary with anatomical variations. It prevents the sudden blast of air from entering the lacrimal sac. This is what happens when the DCR surgery is done. Patient feels this problem. If they come and tell us sudden force of air entering into the conjunctival sac. So gradually they get accustomed to the problem. But usually here it is preventing this natural mechanism is prevention of this air entry. In DCR we cannot preserve that function. The TS usually flow from upper and lower margins, upper and lower caliculi. This I will show you in a, here you can see. See after TS secretion, with the blink of the eye, it's a physiological mechanism. They enter the lacrimal puncta, lacrimal cannula into lacrimal sac. Once the orbicular muscle is used, this is how the tears enter here. And once we open the eye like this, they drain into the NLDO. Again, cycle starts. So this is the normal mechanism. If there is any problem with the lacrimal, with the orbicular muscle also, when there is some weakness of the orbicular muscle or some periocular tissues are loosened because of the old age, senile changes, this mechanism, this pump mechanism fails. It's a physiological pump existing here. This fails and patients continuously complaining of watering and watering and watering. But when we test the ducts here, in this case, and they usually they are patent. But still patient is facing problem of watering because this lacrimal physiological pump failed in certain cases of old age and nervous disorders and all those things. This we need to explain. Usually there is no treatment for this condition except explaining to the patient. But sometimes we can do orbicular ligation, but it's quite a difficult surgery with a lot of complications. Lack of thermus can result. So this is the usual flow from the lacrimal gland and accessory lacrimal glands entering the conjunctival sac and then through the upper and lower canaliculum entering the sac and NLDO into the inferior meatus. So now this is the usual test we do, syringing of the lacrimal canaliculum. So when we enter the canaliculum, we should, there are certain very important steps to take care of this thing. Under topical anesthesia only we should do. Without anesthesia, patient will not cooperate and it will result in false palliation. And again, you should see the tip of that needle. It should be blunt. Any 26 gauge needle we can take and cut the tip and bend it in a 45 degrees angle and use the thing for the syringing. But always the tip should be blunt, not the sharp end. Because the sharp end will damage the cannula and result in a false palliation. So this is how we do the syringing. On syringing we may get 3-4 inferences. One is totally block, all the fluid what we give will come back. Second is if whatever fluid we give, that will come back from the same punctum, that is inferior canaliculus is blocked. Whatever fluid we give, it comes from the upper punctum. If you do from the lower, it is coming from the upper. It means that there is a common canalicular block or maybe NLD block. The differentiation we can do by seeing that X-ray of the fluid. We give saline, it comes pure saline only from the upper punctum. It means that there is a block at the nasolacrimal duct. But if there is lot of turbid fluid or pus coming, means the fluid we injected entered the sac where there is a lot of stagnation. That fluid is coming from the upper punctum. Then you can infer that thing as nasolacrimal duct block. So that is the difference. This syringing inference we should do very carefully to diagnose the condition. Where is the block before attempting the patient for the DCR. And there is another way, another result may come, that is partial block. Part of it is going and patient is feeling the water in his throat or part is coming out. That is partial NLD block. So all these things you should diagnose before surgery. So any doubts or anything in this, I can go for the next topic, that is congenital NLD management.
cardiac anesthesiologist. I am just on doubt. Instead of injecting directly to the syringe, needle, use serum, inject. little bit dive, use serum and see the exact location, where is the block, how is the block. If suppose some block is there, then you can probe it directly under guidance of the serum, and it is a more diagnostic and therapeutic, and you can get full whole anatomy instead of blindly what is your opinion.
Yeah, I agree with you, sir. That's the most scientific way of diagnosing the exact block, as you said, sir. But usually what happens, sir, these facilities are not available everywhere, and most of the ophthalmologists and ENT surgeons in the peripheral area are not having this. So what I was taught and what I am teaching also, the basic minimum facilities available wherever the practitioners are there, what they can do with the patient. Patient coming with a problem of watering from the eye. The first thing we should ask is it only watering, or is there any pus discharge or mucopillar discharge, and how long? Is there any painful situation there, or any abscess is formed there already? And all these things we should ask. Then if there is, after excluding the acute infection part, the first thing we can do is even simpler than this, sir. What I showed is syringing, the thing called syringing. Simpler than that is there procedure. That is called ROPLAS, ROPLAS. That is very interesting term, where regurgitation of pus on pressure of the lacrimal sac. With your thumb or index finger, when you put it over the lacrimal sac area, that is on the medial capital area, once you gentle pressure, you observe either mucopillar or purulent discharge coming from the lower punctum, upper punctum or both puncta. That's it. You need not go for any other investigation regarding this. You can directly, straight away diagnose the case as nasolacrimal duct block, because the proximal pathway is, tissue pathway is normal. Only the nasolacrimal duct is blocked. That's why the accumulated whatever turbulent fluid in the sac is draining through the upper or lower punctum. So you can straight away take the case for the DCR surgery. You need not do syringing also. Only syringing is required when this ROPLAS is negative. When you put a pressure, nothing is coming out. Patient is complaining of water. So then you should do the syringing, see where is the block. Even after syringing, when you are not able to decide the site of block, then as sir said, we can go for various radiological investigations, and also this diagnostistogram, simple dye injection to the punctum, and entire thing will be visualized with a simple X-ray. X-ray also shows up to where the dye entered. That way you can easily diagnose most of the cases. Even other sophisticated diagnostic measures are there. Scintigraphy and MRIs and all the things are available. But usually for a common patient we need not go for this. All those things we can do for the repeat cases. When we do surgery, fail, we are not able to decide where is the block, then we can go send these patients for proper diagnosis of that area and then attempt the exact surgery. Okay? So, yes, sir. But usually that facility is uncommon, like a place like this, Nasrapeta, or even in Vijayawada also, most of the areas. Okay. So they can use the facility as our side and properly diagnose and proceed. But this is what we learned during those times, and I am teaching that. So coming to the congenital nasolacrimal duct block. So what these babies are born with is usually pus discharge at the on the day of birth. But there are so many differential diagnoses for that. Maybe conjunctivitis, congenital or acquired infection to the during the process of birth, and all those gonococcal infections and pneumococcal infections. All these can be easily treated with antibiotic drops and they disappear. But if the watering and pus discharge persisting even after antibiotic treatment for 3 to 4 months, then you should suspect that there is a nasolacrimal duct block. So what is the treatment at various levels? You can diagnose the case with simple Doppler test, or there are certain things like matting of the lashes. When mother says watering, you are not able to see any water there, but if there is, all the lashes are matted, it shows that there is watering and pustules are not at the time of your examination. So you should diagnose like that and then proceed what should be done. That treatment of the congenital NNTO,
Hello?
so it may be bilateral, it may be unilateral, or simple watering or with first discharge. So congenital NNTO, 5% of the babies are born with this problem. 90% open spontaneously in the first year of life. That is very beautiful thing. You should all remember this point. We need not do any intervention up to 1 year, because this naturally opens up with massage or antibiotic drops will help to clear the infection, and sometimes we need to do probing or very rarely tubing. So here you can see there are certain conditions. There is a swelling in the sac area. This can be lacrimal sac mucocele, and more dangerous conditions also. It can be amyloidocele, encephaloceles, meningoceles. All these things can occur in that area. We should not jump into the conclusion that it is a lacrimal sac mucocele and start treating, or if there is any mucopurulent inflammatory changes, some people will directly do the IND and they will end up with major problems if they don't diagnose. Here, sir, it comes with the role of CT scan and MRI. If such swelling is here, we should not jump into the conclusion that it is only lacrimal sac swelling, and we should not go into that thing. So sometimes we need to diagnose it properly, especially in children like this. So then attempt treating them. A course of antibiotics systemically and locally sometimes will help to heal this thing. If it is not healing, we should do the investigations properly and then do the IND if required, which is for the mucopurulent accumulation in the lacrimal sac area. So massage of the lacrimal duct, nasolacrimal duct, and antibiotic drops 4 times a day, and usually it improves by the age of 12 months in 95% of cases. And if there is no improvement, probing at 12 to 18 months results 90% of cure by first probing and 6 or 7% second probing. If it is not curing after second or third probing, we should not re-attempt the case. We should keep the case for early DCR surgery. Usually textbook says the earliest DCR surgery under general anesthesia is 4 years or 5 years. But my way of treatment of these patients little differs. These are all textbook advices. But in our Indian scenario, the condition is totally different. A baby is brought with such first discharge, even after 6 months or 8 months of massage and antibiotics. I will not ultra small ketamine, 5 minutes procedure, do the probing, relieve the problem to the parents and to the baby, to everybody. Further, he may not continue the massage like that. How many days? Sometimes this massage, if they don't do properly, that will cause a big access there. How many Indian mothers understand the correct way of massage? How many doctors are having time to explain the massage? So they just say massage and say next patient type usual practice. And mother will go and do massage somewhere there and cause the big abscess there. And second thing, nowadays parents are not having that much energies and interest to cure it non-surgical way. So they don't do these things properly. So patient is suffering and the infection can spread to the eye. So early probing I suggested initially in 1994-95 that presented paper early probing. Everybody before 1 year she wants to do the probing. I given proper reasons why I should. Indian scenario is totally different from the Western scenario. There they can wait for 1 year, but not here. Here lot of infections. The lacrimal sac infections can spread to the orbit and cellulitis and losing the sight. Lot of problems. So better to do the simple procedure of probing properly. One probing 95% result, second probing less than 6% result. Alas. So why to wait for the probing 1 year, 2 years? This is all. I am not following that procedure. And second thing is this massage. How to do it? Put the finger at the medial canthal area over the sac area. Firmly give the pressure posteriorly, then inferiorly, and lightly medially. If mother is doing this massage 3 times a day, 60 to 70% of cases will cure, because we are creating a volume vacuum there. That vacuum is opening the membranous obstruction between the lacrimal sac and the NLD. So usually that clears completely. But if still that membrane is thickened or already bony formation is there, all these cases the massage fails. Then we need to intervene with probing. And proper explanation of this massage is very important, especially doctors. We are not very good at explaining. That's why all these failures are occurring. So this is the lacrimal sac abscess formed already because of bad massage. So coming to the probing, so we again recollect this probing. The anatomy you should recollect: 2 millimeters vertical, 8 millimeters horizontal. Either it will end into common canuliculi or individual canuliculi into the sac. 10 millimeters sac, 12 millimeters NLDO. These measurements are usually there, but there may be anatomical variations. But we should remember this pathway. Otherwise, you cannot bluntly push the probe and cause the false positives. And this is especially for our ENT colleagues, because I don't know what is happening recently, but initially when the endonasal DCRs coming into the practice, most of our ENT colleagues are calling us for identifying the lower punctum, canaliculus, and passing the probe, and all these things. Once we identify, they are making the passages successfully through the endoscopic endonasal DCR. But of late, ENT colleagues also should learn this anatomy. If you are planning to practice endonasal, endoscopic or laser DCRs, but this anatomy should be learned properly. Otherwise, your endonasal DCR will result in a failure because of this problem. This is canalicular injury, canalicular stenosis. This is very, very, very difficult to treat. After once this problem occurs, this complication occurs, we need to do bilateral upper and bicanalicular stenting. We should do. The stents will not stay there 3 to 4 months. They should stay, especially in children. They remove them by pulling from the nose, and all that is again fail. Once it and ultimately results lifelong watering. So better to learn the anatomy properly and attempt the thing. This is how first step is putting the nettleship punctal dilator. This instrument for the postgraduates, this is the name of the instrument is punctal dilator, nettleship punctal dilator. First you pass this, dilate the punctum, dilate the ampulla, and then pass this probe. There are various sizes of the probe. This is Bowman's probes. Bowman probe from 0 to 4 size are there. Initially with 4 size, small size we should start, and gradually dilate this canaliculi. You can start with the lower canaliculus or with the upper canaliculus. Enter the lacrimal sac. So once you enter the lacrimal sac here, you can get 2 types of feeling: hard stop, soft stop. Hard stop means once you touch there is a problem at the common canaliculus and lacrimal sac area. So it will result in the soft stop. You will not touch the bone. There is a soft feeling there. So in that case, your probing is going to fail 100%. You stop there and come out. If there is a soft stop. So if there is hard stop means your probe entered the sac, touched this wall of the sac, this medial wall of the sac, and you are touching the bone also behind it. So you feel the hard stop, then you can proceed with further this thing. Here you can see hard stop means this is one membranous feeling you can get. Bony feeling you get. Soft stop means your canaliculus is dragged here and it is resulting here this soft stop here. You can see here. So here you should not continue with your probing. This will definitely result in the false passage. So you can proceed here but not here. So then step is vertical, go vertically down and enter the NLTO. So these are the instruments usually do Bowman's probes and little chip punctal dilator. So this is how the probe is passed here through the lower punctum, and here double checking with another probe through the nose. Both metal touch, tick tick sound you can hear. Then you mean that you are proper place. As sir said, these are the blind procedures, but we are doing, and most of the things are we are getting the results properly. We are still following, but you can do it.
Hello, auditorium.
Sufficient way under the visual.
Hello, auditorium.
Hello,
Sujatha madam.
Hello.
Hello, Sekhar.
Madam, we are ready with the case, madam. Patient has been intubated already.
Okay, sir. Okay.
We will do the discussion while we do the external DCR, madam.
Okay, sir.
Okay, sorry to disturb you, madam.
No problem. This probing is over. Only a video should be shown, but let